Hello, everyone. It's a great pleasure to be with you. I wish I could be there in person, but happy to be there virtually. And today I'll be covering for endovascular therapy for acute ischemic stroke, two subtopics: how the American Heart, American Stroke Association has set up quality and performance metrics and systems in the US and the world that are available, and also some recent NIH research systems update in this space. Here are my disclosures. And in the course of the talk, I'll talk about the regional systems of care approach in the US, the required resources for stroke centers, and performance and quality metrics that are used in both the Get With the Guidelines stroke program and the Target stroke program, and then close talking about the new NIH platform for endovascular thrombectomy trials. The US, with AHA policy framing, has established a 4-level regional system of care approach for acute stroke. It begins with the EMS system and trained personnel to recognize stroke and stroke severity and triage patients to the most appropriate receiving hospital. There are 4 levels of receiving hospital in 2 domains. Frontline hospitals, the spokes, include acute stroke-ready hospitals that are able to provide initial ED care and can use thrombolytics, often by telemedicine, and then through drip and ship can send the patient up the chain to a more advanced hospital rapidly. Primary stroke centers are hospitals with organized inpatient stroke care and capable of doing intravenous thrombolysis. They do not have endovascular thrombectomy capability. Those are contained by hub hospitals, the comprehensive stroke centers that are the most detailed in care, able to care for complex neurosurgery cases, neurocritical care patients, as well as thrombectomy, and also an intermediate group recently established of thrombectomy stroke centers that are like primary stroke centers, but can also do thrombectomy, although not detailed neurosurgical care. So here are the capabilities of the system for both hemorrhage and ischemic stroke management. And every regional EMS medical director looks at the hospitals in their area and weaves the geography and their resources into the best system for getting patients to these hospitals. The endovascular thrombectomy is delivered at the comprehensive stroke centers, and the comprehensive stroke center movement in the US has been led by AHA, ASA over the past decade, beginning with pilot testing and then having a national joint certification program with the Joint Commission, and then policy papers on the components of comprehensive centers and pre-hospital routing policies. And so what are the recommendations for comprehensive stroke center? First, with regard to their capabilities, they are to have catheter angiography suites available around the clock, along with advanced multimodal imaging, CT, CTP, CTA, and MRA and diffusion. They need a neurointensive care unit. They need to do minimum volumes of care for both ischemic and hemorrhagic disease. They need to be engaged in continuous quality improvement, but also patient-centered research. And they need to meet quality goals and collect data continuously on all the same care metrics as primary stroke centers, but also specific metrics for comprehensive stroke centers. As of today, a decade into this program, Of the 4,500 acute care hospitals in the US, about 2,100 are within the Get With the Guidelines Stroke program. So this system of quality improvement is in the majority of hospitals, and especially the moderate size and larger ones. So it's being used in probably about 3/4 of all stroke patients in the US. Acute stroke ready hospitals are represent maybe 100 of these facilities. The largest component of the primary stroke centers, there are probably 200 to 250 comprehensive stroke centers and a smaller number of thrombectomy stroke centers. And in general, in any region, the ratio is 5 to 10 spoke hospitals to every one hub hospital. And here are the measures that stroke centers, through the Hospital Accreditation Committee, the Joint Commission, are required to meet. This is for all stroke centers, and it involves supportive care with venous thromboembolism prophylaxis, discharge and antithrombotic therapy, being able to deliver thrombolysis, and other aspects of the in-hospital assessment, management, and early institution of secondary prevention. But specifically for endovascular care, we have the metrics for the comprehensive stroke centers that are national quality measures. And here you can see the 10 current quality measures. Some are for hemorrhagic disease, but fully 7 of them are for patients with endovascular thrombectomy. They have to have an NIH stroke scale score performed on arrival to assess severity. Tracking needs to be done of rates of hemorrhagic transformation for both lytic treated and thrombectomy treated patients. The successful reperfusion rate, TICI-2B3, after thrombectomy needs to be tracked. The speed of care, time from door to skin puncture, door to substantial reperfusion, and puncture to substantial reperfusion needs to be tracked. And then the final patient outcome at day 90 with a modified Rankin scale measure of global disability needs to be tracked. In addition, comprehensive stroke centers are expected to track complications of 10 procedures, including diagnostic cerebral angiography and endovascular thrombectomy, as well as a variety of neurosurgical and vascular surgical procedures. Now, in addition to those metrics that are part of the Get With the Guidelines Stroke program, those metrics are kind of a floor that we expect every hospital to be able to meet. The American Heart Association, Stroke Association has also launched the Target Stroke campaign. And Target Stroke is more of an aspirational quality improvement program, establishing stretch targets, ceiling targets for hospitals to aspire to. It's important not to just have everyone feel that they are have achieved enough success if they've just cleared the performance standards. We want them to be continuously striving to do better and better. And so we've had 2 prior phases of Target Stroke, beginning in 2009 with Target Stroke Phase 1 and 2013 Target Stroke Phase 2. And these were focused on thrombolysis and speeding door to needle times. And you can see that there was a substantial change nationally in the US in the acceleration of speed to thrombolysis with the start of the Target Stroke programs. This is one of the most successful national quality improvement programs for any disease state in improvement medicine. Then, more recently, of course, we have the breakthroughs with the positive thrombectomy trials and entered an era of highly effective endovascular reperfusion therapy. And we know that time to treatment is as or even more important for endovascular thrombectomy for improved outcome as it is for ischemic stroke thrombolysis. Here from the pooled analysis of the Hermes 5 trials, we can see the decline in benefit over the first 7 to 8 hours in relatively unselected patients, and the number of every 100 patients treated who benefit from therapy declining substantially as every minute goes by. In fact, every 4 minutes, one more patient has missed a chance for a better disability outcome in start of therapy. So in Target Stroke Phase 3, which was launched 2 years ago, we not only increased the goals for thrombolysis, and in improvement science, you're always, as they say in the US, moving the goalposts. When you achieve one target, then you set a new higher target. And so the new target for intravenous thrombolysis is door to needle time under 60 minutes in 85% of patients, under 45 minutes in 3/4, and for the first time under 30 minutes in half of patients. But also for the first time, we've established endovascular targets, door to device time. So this is time to first device deployment in the target thrombus, either placement of the aspiration device within or against the clot, or deployment of a stent retriever within the clot. And we have 2 different targets for patients who arrive directly to the thrombectomy hospital from the field. The door to device time target is under 90 minutes in half of patients. On the other hand, for patients who arrive by transfer from another facility, there the thrombectomy stroke center has time to know that the patient's on the way, more time than with even with EMS pre-notification, and they can get all their systems in place. Plus, the patient will have undergone imaging already at the outside hospital that may not need to be repeated. And so a shorter goal is established for interfacility transfer patients, a door to device time of under 60 minutes in 50% or more of patients. And as part of this program, we've established best practice strategies that have evidence in the literature that are circulated to all the participating hospitals. And this includes getting CT and MRA concurrently with the initial imaging, doing pre-notification and early activation of the interventional team when the case is beginning to be evaluated, not waiting till you're absolutely sure you're heading to the cath lab, making sure that all members, both physicians and technologists and nurses of neurointerventional team, are near the hospital and able to come in quickly, having in select patients going straight to the angio suite, especially if they've been imaged at an outside hospital, and having an endovascular ready neurangio suite with the entire tool set ready to be pulled out, and prompt data feedback after every case. At our site at UCLA, to help accelerate treatment decision-making in patients going to endovascular thrombectomy, we've developed these decision aids for patients and families that show among patients who are getting TPA plus thrombectomy versus TPA alone, TPA eligible patients, or patients ineligible for TPA who are going to get thrombectomy versus no intervention. Among 100 patients treated, in dark green, the ones who have an excellent outcome as a result of therapy. In light green, the ones who will have a better outcome than they would have as a result of therapy. And in red, the ones who have a worse outcome than they would have as a result of therapy. And this is able to visually encapsulate for the decision makers very rapidly the dramatic benefits of thrombectomy in acute ischemic stroke. Just out within the last few months from AHA-ASA are these recommendations for regional stroke destination plans in rural, urban, and suburban communities. These indicate that if a large vessel occlusion is suspected by paramedics in the field after they've performed a stroke severity instrument, they should bring those patients to the nearest comprehensive or thrombectomy stroke hospital if it is within 30 minutes of their location. That's for urban settings. For suburban and rural settings, it could be 45 or 60 minutes if the EMS system can tolerate having the ambulance out of their service area for that duration. And to show you the type of impact that setting up these regional systems of care has had in the US, here's data from LA County, where we have 10 million people. And in 2018, we implemented a two-tier routing system, going from bringing all patients to just the nearest primary stroke center to bringing patients with likely large vessel occlusions on the Los Angeles Motor Scale score to thrombectomy stroke centers. And we saw that the population of the county with 30-minute access to thrombectomy stroke centers increased from 40% to 93%. And TPA administrations were slightly increased, actually, even with the introduction of direct routing to thrombectomy hospitals. But dramatically, the number of ambulance transported patients who received thrombectomy increased from 5% to 14%. Also, the number of interfacility transfers for stroke went down 2/3, reflecting the fact that patients were being brought to the right destination hospital right from the beginning. In the Get With the Guidelines program, we have a patient case report form that collects about 150 data fields on each patient and allows each hospital to track how it's doing and to compare their performance to all hospitals in the US and to all similar hospitals in an anonymous manner. Currently, there are about 5 million patient records in Get With the Guidelines stroke, and about 500,000 new patients are being entered each year. And this data is able to be forwarded for performance measure assessment to certifying agencies. If hospitals have performed well on meeting quality metrics, they have annual awards that are received and published in the a national US magazine, US News and World Report, showing that hospitals have received bronze or silver, or in our case, gold plus awards from the Get With the Guidelines stroke program. And this helps to reward all of the personnel involved in endovascular care and keeps them on their toes for doing well. Here's how we track performance monthly at our own site on achieving defect-free care in these performance measures for primary stroke centers. And here you can see how we initially started tracking for comprehensive stroke centers metrics, and with some already performing well, but others that we needed to work on and continually sought to improve. Now, in closing, let me briefly turn from quality systems of care in the US for endovascular thrombectomy to an exciting new potential program from NIH of developing an endovascular thrombectomy trials platform. Platform trials are the hottest thing these days in clinical trials. They not only have set networks that together perform studies, but share data in studies from one study to the next. There can be shared controls, there can be borrowed information from factorial designs. So it's a shared inferential space in addition to a shared performance space, and that lets you much more efficiently explore the universe of potential therapies for patients. And they started in cancer, have begun to be developed for neurologic diseases, and NIH issued a call for endovascular thrombectomy trial platform in the past year. I'm part of the STEP group that is one of the applicants to set this up. We've proposed a 30 to 50 center network that would seek to approach patients in this manner. Here's where we stand with endovascular thrombectomy in terms of time to treatment and amount of penumbra, amount of mismatch. We know from the initial Hermes trials, under 6 hours, everyone almost benefits. We know from the Fuse 3 that extreme mismatch patients benefit up to 16 hours and Dawn up to 24 hours. But all of these cells are not yet answered. And we need to explore them in part by borrowing information from other cells to make it more efficient. Similarly, we know from the initial trials that there's great benefit for patients with large vessel occlusions and small cores, and severe neurologic deficits. But we want to also know whether there's benefit for medium vessel occlusions, mild deficit patients, and large core patients, and all of the cells that these patients form. So we have to explore all these new decisional spaces, looking at the multiple parameters that affect whether an individual patient will benefit. And in the old days, we would do one trial at a time to explore each of these spaces. That's a very inefficient manner. But the new approach are platform trials in which multiple trials are done at the same time. We are still seeing in the field the classic approach. There are some industry sponsored and some government sponsored single target trials out there, slowly exploring this space. But in the STEP platform, we would have multiple trials running at the same time, borrowing information from each other. As one trial completes, another one is brought onto the platform, and they would explore expanding the indication for thrombectomy to new populations, explore innovative concomitant therapies, neuroprotection drugs, and novel devices to better recanalization devices, and also explore better ways of organizing systems of care, both pre-hospital and in-hospital, all under a single master protocol. So that organized, integrated approach is now extending to research into thrombectomy, but is well established in quality of care and improvement science for endovascular thrombectomy. And I know it has been a great pleasure working with the Middle Eastern region on jointly developing these systems of care. We greatly look forward to continuing to do so. Thank you very much for your attention.